The President. Questions. Question 1, Professor Priscilla LEUNG. President, it has been reported that the situation of Hong Kong residents returning to Hong Kong for medical treatment after settling overseas for years has persisted for a long while. Among them, many are patients suffering from catastrophic illnesses such as cancer, and some of them are referred to public hospitals for further treatment after receiving preliminary treatment in private hospitals. Regarding the manpower and resources for public health care services, will the government inform this council? 1. As a professor of a medical school at a university has reportedly pointed out that the number of patients returning to Hong Kong for medical treatment has slightly increased by 5 to 10% in recent years, whether the government has compiled statistics on the exact figures and assessed if the existing manpower and resources for public hospitals can cope with the increase in the number of patients. 2. As the Secretary for Health indicated in a media interview in August last year, that more than half of the local doctors were practicing in the private market, serving about 13% of the patients in Hong Kong, which in effect means that less than half of the local doctors were practicing under the public health care system, taking care of nearly 90% of the patients in Hong Kong. Whether the government has compiled statistics on the latest figures and formulated corresponding plans. And 3, as it has been reported that a survey conducted by the Hong Kong Academy of Medicine, or HKAM, in 2019 found that over 70% of the local young doctors interviewed showed signs of overexertion at work, and more than 20% of the doctors interviewed even had the problem of depression. Whether the government has gained an understanding of the actual situation and what corresponding plans it has put in place. Secretary for Health. President, I thank Professor Priscilla LEUNG for a question on public health care manpower. This is also a problem we are concerned about. Public health care is the cornerstone and safety net of the healthcare system of Hong Kong. As the backbone of the public healthcare system, the HA provides healthcare services heavily subsidized by the government, as high as 97%, and is positioned to serve disadvantaged groups, provide acute and emergency care, to provide treatments for severe diseases and those involving complex procedures, as well as to support teaching, training, and research. At present, all holders of a valid Hong Kong ID card and children under 11 years of age who are Hong Kong residents can use subsidized public health care services as eligible persons or EPs. There is no requirement for service users to ordinarily reside in Hong Kong. The HA does not collect information on whether individual patients ordinarily reside in Hong Kong, nor does it compile statistics on the utilization of public health care services by EPs who do not ordinarily reside in Hong Kong. At present, it is uncertain if a large number of EPs who have moved overseas earlier and returned to Hong Kong are using our public health care services. The definition of EPs form part of the policy of fees and charges for public health care services. When reviewing the relevant policy, according to the related mechanisms, the government and the HA will keep in view changes to the patterns of Hong Kong residents in moving to the mainland and overseas, as well as make reference to the subsidization policies of other public services. 2 and 3. As of the 31st of March 2024, there are 16,459 doctors in Hong Kong. That is, only 2.16 doctors per 1,000 persons, a ratio far lower than that of other advanced economies. While the public and private sectors each has around half of the doctor manpower, the public healthcare system provides 90% of inpatient services in Hong Kong. It is undisputed there is a shortage of healthcare manpower in Hong Kong, and the workload of healthcare professionals is immense. I would first like to express my sincere gratitude to healthcare staff, especially those working in the public healthcare system, for their unfailing efforts in providing efficient and appropriate services to the public. To relieve the burden on the public healthcare system, especially those working in public hospitals, the government is committed to implementing a series of measures, including development of primary health care, strengthening resources and manpower, as well as improving service efficiency. The primary healthcare blueprint puts in place the prevention-oriented, community-based and family-centric approach, strengthening the concepts of family doctor for all, and early identification and early treatment, etc., with a view to improving the overall population health and establishing a sustainable system. To strengthen manpower, the government has stepped up the investment of resources on training of healthcare professionals in recent years. The training capacity for various healthcare professions has increased significantly by 50% in 6 years, from about 4,000 in 2017 to 18 to about 6,000 in 2023 to 24. Apart from the creation of new pathways for the admission of non-locally trained doctors through the earlier amendments to the Medical Registration Ordinance, we have successively introduced bills to the Legislative Council to create new pathways for the admission of non-locally trained nurses and dentists. We are also exploring the introduction of qualified, non-locally trained supplementary medical professionals for working in the HA and the Departments of Health, and will propose legislative amendments as soon as possible. The HA also established the task group on sustainability earlier to review various challenges including manpower shortage, as well as formulate strategies and implement various measures to attract, develop, and retain talents. These include enhancing recruitment of local medical graduates, rehiring retired staff, and recruiting non-locally trained doctors and part-time healthcare staff, while enhancing training and promotion opportunities, as well as launching the enhanced home loan interest subsidy scheme, etc. The measures have started to yield results. The number of doctors in the HA has increased by more than 260 in 2023 and 24 as compared with the previous year, while the attrition rate has dropped from the peak at 8.1% in 2021-22 to 5.2% in 2023 and 24. The physical and mental health of doctors is closely related to the provision of quality healthcare services. We value the survey conducted by the HAM 5 years ago in 2019, as mentioned in the question. In view of the survey results, the HAM launched the Well-being Charter in 2021 to put more emphasis on the promotion of the physical and mental health of healthcare staff through the ASAP model, namely awareness, self-care, ask for help, and promotion of well-beings, so as to effectively prevent stress and overwork. The HKAM also established the Task Force on Well-being for planning and implementing various measures. These include measuring different levels of work-related burnout and exhaustion through the Copenhagen Burnout Inventory questionnaire, recruiting peer supporters who learn about relevant support tips and practical skills through the training course designed by the Hong Kong College of Psychiatrists, and organizing diversified outdoor sports and recreation activities to help doctors relieve fatigue and stress. As for the public health care system, the HA puts great emphasis on the mental health of their staff. The oasis of the corporate clinical psychology services under the HA head office, the 8 critical incident psychological services centers in the clusters, and the 30 critical incident support teams in the hospitals are committed to providing various mental health services to employees, including individual counseling, treatment groups, crisis intervention, and mental health promotion, etc., to enhance colleagues' mental health and resilience. Apart from those measures targeting the mental health of healthcare staff, with measures to attract and retain talents gradually proving effective, the manpower situation and the work pressure of healthcare staff will also be improved. The HA will also develop smart healthcare to continuously improve service quality and enhance efficiency. The HA will continue to closely monitor the manpower situation and adopt active measures to support overall service demand and developments. Thank you, President. Professor Leung. First of all, I would like to salute healthcare professionals serving the public sector. Now, our public healthcare system is renowned in the world. Now, with a trend of aging population in the world, lots of overseas Hong Kongers are coming back to receive treatment. I think the government and the HA must take a scientific approach to plan ahead. For instance, conducting census and surveys. Now, in part 2 of the reply of my question, there should be better matching between healthcare professionals and the public healthcare system. Professor Leung, please raise your question. I have. That is, can the government add an item to your census and survey? Now, surveying the overseas Hong Kongers coming back to Hong Kong for treatment. Professor Low. Thank you, Professor Leung, for your question. First, we need to define who are those Hong Kongers who have moved permanently overseas. At present, eligible persons mean a holder of a valid Hong Kong ID card. In other words, if a person still holds a Hong Kong ID card, it would not be right to revoke their rights to receive free treatment in a public healthcare system. We need to take a very careful approach. This isn't just a matter in relation to public healthcare. It also has a bearing on the eligibility for social welfare and benefits. Professor Leung, the Secretary has answered your question. Dr. Dennis Lam. Thank you, President. Now, there is not a policy dealing with the issue. However, it is only natural for local Hong Kongers to be given a heavily subsidized public healthcare treatment. For those Hong Kongers who are granted with overseas citizenship, they are still eligible for our free service. Looking forward, will the government review this policy? You have raised your question already. Secretary. I believe my answer is the same as the previous one. This is a very important policy change. There are lots of nationals there are a lot of people from different nationalities who are holding valid Hong Kong ID card in Hong Kong. So how should we define those who have moved overseas permanently? We understand that some people would choose to return to Hong Kong to live permanently after some time. So how do we define this? 6 months prior the receipt of treatment? So we need to take a broader perspective in this. Ms. Lillian Kwok. Thank you, President. Concerning our public healthcare service, I'm concerned about public healthcare services for students. Now, the students' health program includes assessments on students' height, weight, hearing, and vision. Now, we have fewer than 40,000 new births each year. However, we are still allocating the same amount of resources to the student healthcare program. Now, the items of checks and treatments didn't change for decades. Can the government review the manpower and resources attached to the program so that the program can meet modern needs while saving manpower? I don't want to see the program unchanged for 50 years. Secretary. I thank Ms. Lillian Kwok for your question. Now, the student healthcare program is run by the Department of Health. The question today is about manpower and resources for public healthcare services. Still, I will attempt to answer your question. The student healthcare program is a comprehensive program offered by the Department of Health to monitor the health of students. It is a voluntary program. The schools will need to sign up for the program, and the Department of Health would even arrange for transport to take students to receive consultation. Now, the 3-year pandemic has affected the delivery of the program. Healthcare professionals were drawn away for anti-epidemic duties, and because of the closure of schools, the program was affected to a certain extent. However, after the easing of the pandemic, the Department of Health has resumed promoting the program. Schools are encouraged to give priority to the program because spending half a day to receive health checks is important for students' health. Now, this is a very comprehensive program from height, weight, students' vision, and even mental health. The check is very comprehensive. We will continue to review the student healthcare program and add new items for check in the future. The Department of Health will step up publicity to encourage students to sign up for the program to improve the health of the next generation. Now, separately, we have published a new report on the growth statistics of our adolescents. In the past 18 years, the height of our adolescents has increased by 2 centimeters. So these are helpful for monitoring the health of our youngsters. Mr. Edmund Wong. Thank you, President. Now, there are no new policies to address the issue. Now, because of the shortage of healthcare manpower in the public healthcare system, the government has extended the list of recognized overseas medical institutions. Now, since the launch of the scheme on the 29th of April 2022, how many doctors and how many specialists overseas have been approved to practice in Hong Kong? Secretary. I thank the member for his question. In recruiting non-locally trained doctors, there are 2 pathways. One is limited registration, the other is special registration. As at the 31st of May 2024, there are 144 non-locally trained doctors in the HA. 92 are under limited registration and 52 under special registration. According to our estimation, because of our enhanced efforts to recruit non-locally trained doctors, by the end of this year, we expect 250 non-locally trained doctors joining the HA to alleviate the burden on the public healthcare system. Mr. Adrian Ho, thank you. Earlier on, the medical school of the University of Hong Kong received $1.3 billion from the Hong Kong Jockey Club to establish a cancer care center and receive referrals from the private sector. Now, I hope there will be more support given to cancer patients in the future, and also alleviates the burden of the public healthcare system to reduce overexertion and depression of our local doctors, so that they would follow in the steps of the Secretary to give birth early. Now, will the Secretary make reference to the model of the University of Hong Kong Center for Cancer Care to other special and rare diseases? Secretary. Concerning the establishment of the Cancer Center of the HKU, the healthcare professionals comprise doctors and nurses from the 16,000 strong talent pool in Hong Kong. Now, concerning the establishment of centers for cancer and rare disease patients, this is also the direction pursued by this term of the government. In the policy address, the chief executive announced the establishment of cardiovascular treatment center and neuroscience center. Now, for these complicated disciplines, we need cross-discipline treatment plan. High-risk treatment regime and surgeries are involved. So we need to focus these services in centers for excellence rather than scattering them in different hospitals. This is also the positioning of the HA, that is to take care of patients with serious illness requiring complicated treatment. The best solution is to concentrate the services in centers for excellence. Mr. Chang Hai-leung. Thank you, President. Now, there is a persistent shortage of healthcare manpower in public healthcare sector. Now, there are rumors that the HKUST is going to establish the third medical school in Hong Kong. Does the Secretary support that? Secretary. Now, we are pleased to hear that one of our universities has the intent to establish the third medical school. Actually, other universities have raised similar proposals. Now, with a third medical school, we can step up the training quota for healthcare manpower, provided that all the conditions are met. But there are other options as well. We are continuously expanding the training quotas with the 2 medical schools. Over the past 6 years, we have increased the training quotas from 290 to 490 each year, or rather 590 per year in total. Concerning which university would be the one to give us the third medical school, it depends on the proposals raised by the institution. A number of factors are involved, including the hardware, where the medical school will be built, and the availability of a training hospital is also important. It also involves the source of students. The 2 existing medical schools have taken on board a lot of quality students. So do we have a new source of medical students for the third school? Also, the source of training manpower for the third school. We would undermine the existing training manpower of the existing medical schools. These are all our considerations. After receiving a formal, detailed proposal, we will make an assessment. Thank you.
Question to Dr. David Lam. Thank you, President. The government set up the Kwai Tsing District Health Center, the first DHC in Hong Kong, in 2019, and subsequently set up DHCs or District Health Center Expresses or DHCEs in various districts across the city. These facilities have been serving the public for nearly 5 years. Still, some members of the public have said that apart from health promotion programs and the chronic disease co-care pilot scheme, they know little about the other services provided by DHCs and DHCEs. In this connection, will the government inform this council first whether it has reviewed in a timely manner the roles and functions of DHCs in primary healthcare services such as medication management, vaccination, and rehabilitation treatment, as well as the effectiveness of their services provided in collaboration with various private healthcare service providers in the community? If so, of the details, if not, the reasons for that. Second, whether it has upheld the role of DHCs as case managers and service providers for patients discharged from public hospitals for community rehabilitation. And third, whether it has plans to effectively link up healthcare service providers in the community and the public through DHCs so as to introduce diversified healthcare services for the public. If so, of the details of the new services, if not, the reasons for that. Secretary for Health. I'm grateful to the question from Dr. David Lam. The first DHC or District Health Center was set up in September 2019 in Kuai-ching District, but then we had COVID starting from 2020. COVID raged on for 3 years or so. The Kuai-ching DHC played an active part in fighting COVID. In terms of the DHC's development, that suffered a major blow. But then COVID eased. In December 2022, the government released the Primary Healthcare Blueprint, setting out a range of measures. One key area was to use this DHC model to start a community-based, family-centric primary healthcare system in the community. In the end of 2022, the government set up DHCs or DHCEs of a smaller scale across all districts. At that point, we reached the interim goal of having DHCs or DHCEs across the city. We will continue to build DHCs in Hong Kong. Within 2025, we will upgrade the 3 DHC expresses in the Central and Western District, Yau Chi Mall District, and Eastern District into DHCs. By then, more than half of our district, that is 10 districts, will have DHCs in place to serve the people. Each DHC will also set up several satellite centers or service points to expand public reach. DHCs mainly provide health promotion, health risk factors assessment, disease screening, chronic disease management, and community rehabilitation services. As normal life was back after COVID, we launched the Chronic Disease Co-Care Pilot Scheme in November 2023 to provide targeted subsidies to citizens for diagnosis and management of chronic diseases in private healthcare systems under a co-payment model. After the scheme's launch, as at the end of June this year, 45,000 people had taken part in the scheme. Nearly 40% of those who had completed screening were diagnosed with hypertension, prediabetes, and diabetes mellitus. The scheme also establishes a family doctor network in the community and supports participants in receiving long-term follow-up. DHCs help promote the family doctor for all concept, and such role has been further enhanced after the scheme's rollout. We noticed a marked increase in the number of DHC members after the scheme was launched. The number of new DHC members per year increased from roughly 2,900 in 2019 to 20 to about, and that is more than 36-fold increase. That's roughly 106,400 in 2023 to 24. To date, the number of DHC members has reached 263,400 people. The first DHC was started in September 2019, and then up to the end of March 2024, more than 1.55 million people have received services there. Details are set out in the annex. The government commissioned the Chinese University of Hong Kong to conduct a monitoring and evaluation study of the DHCs, which showed that DHC members were happy with the DHC services and believe those services helped them enhance their health awareness. These results show the DHCs have gradually been building a primary healthcare service network which is taking shape in the community, thanks to the support from members of the Legislative Council, healthcare professionals, and the community as a whole. As the community primary healthcare resource hub, DHCs act as coordinators of primary healthcare services in the community and case managers. In this regard, DHCs will enhance its services in 3 aspects. First, the establishment of a multidisciplinary service providers network. DHCs will work with a wider range of healthcare professionals to provide the public with more diversified services. For example, DHCs, in collaboration with the Hong Kong Jockey Club Charities Trust, started the Community Pharmacy Project in mid-June this year, allowing the public to opt for drug consultation and dispensing services in the community. Second, on mental health, 3 DHCs will launch a pilot program this year to provide mental health assessment, early follow-up, and referral for high-risk cases in collaboration with community bodies. Third, on Chinese medicine, or CM, DHCs will establish a service network with CM practitioners and provide personalized CM services under a co-payment model. Fourth, community rehabilitation. DHCs have established referral mechanisms with various clusters of the hospital authority, where DHCs will provide rehabilitation and follow-up services for referred patients with strokes, hip fractures, or post-acute myocardial infarction. As at the 31st of March this year, the cumulative service attendance of a community rehabilitation program was around 34,000 people. DHCs also play a proactive part in flu vaccination. In 2023-24, DHCs have arranged more than 210 vaccination sessions. In addition, the Strategic Purchasing Office will also procure nursing and allied health services from the private sector to support DHCs. This way, DHCs can play a role as a community primary healthcare hub in various ways. Now, strengthening community ties is another priority for DHCs. DHCs have established a regular cooperation mechanism with around 1,000 community bodies. In April this year, the government held a briefing session introducing primary healthcare services to roughly 200 district councillors. The government will also continue to work with local community service partners, including healthcares, in promoting primary healthcare. DHCs have also started working with the operators of transitional housing and will visit 35 transitional housing projects this year to provide those residents with health risk assessment and health education activities. Third, promoting the concept of people-centered disease prevention. DHCs provide whole person primary healthcare services and attend to individuals' health at different stages of their lives. Now, based on the Hong Kong Reference Framework for Life Course Preventive Care in Primary Healthcare, a comprehensive set of guidance on disease prevention and health advice are given to people at different stages of their lives. DHCs will further enhance the depth and breadth of its services to tackle the pattern that men are less likely to actively access preventive primary health care. DHCs will proactively work with different sectors in proactively reaching out to men groups. We will also be gradually integrating the primary healthcare services under the Department of Health, including women health centers and elderly health centers, into DHCs. We will continue to review and respond to the community's needs and strengthen DHC services to optimize the community healthcare system. Thank you. Dr. David Lam. Thank you, President. I thank the Secretary for his response. District health centers are a hub in primary health care. These centers coordinate the services, and the services are taking shape. Now, my follow-up question. For discharged patients from the hospital authority, they get rehabilitation care at DHCs. Does that actually shorten the hospital stay for patients? DHCs cater to the needs of discharged patients. Will the government consider working with the other community healthcare professionals such that these professionals can provide the services? That way, DHCs can actually coordinate the services rather than providing the services themselves. Secretary, I thank Dr. Lam for his question. He also gave us suggestions, and that's a great idea. On the community rehabilitation program, we have in place a referral mechanism. The hospital authority refers hospital patients to the community for rehabilitation. Based on what we have at hand, 34,000 people are taking part in this arrangement. On the idea of shortening the hospital stay of patients, this is one thing we will look at in assessing the success of our scheme. We will be compiling data on that. Now, we're still in the early days of this program, so we don't have enough data to show us the difference in hospital stay. On working with the other rehab care providers in the community, as we promote primary health care, we want to take a multidisciplinary approach. In strategic purchasing, we also take a public-private partnership approach. This is also our direction, and I thank the member for his support for the program. Mr. Michael Lee. Thank you, President. I agree that we have to strengthen our DHCs. Now I have some questions about Chinese medicine services. At each DHC, they provide just around 100 events or activities for CM. I think that falls short of the primary healthcare blueprint and the policy address, which project a stronger role for CM in primary healthcare. CM is popular in the community. On preventive care and alleviating pain, symptoms, and strokes, people believe in CM, and that confidence is growing. What plans are there to step up and increase CM services at DHCs so that Chinese medicine can play a greater role in protecting people's health? Secretary. I agree with the member that CM should play a greater role in healthcare. At DHCs, especially for the new centers, we will continue to promote the use of CM. At existing DCHCs, members can access a scheme with CM, especially for rehab, for stroke patients, and also for those with degenerative arthritic conditions and also lower back pain. The bodies running the DHCs have a service network with CM practitioners. There's a funding mechanism. For people taking part in the scheme, they can receive personalized CM services or other healthcare services under a co-payment model. So for pain symptoms, they can access acupuncture. As at the end of the first quarter of this year, DHCs have reached out to roughly 400 CM practitioners as network service providers for the HCs. Patients with the conditions I mentioned can go for these subsidized CM services, acupuncture, and pressure and massaging. These CM practitioners provide preventive and health maintenance education, and this also covers dieting advice. DHCs also work with Chinese medicine teaching and research centers. These centers help these DHCs provide various CM services. As at the 31st of March this year, the CM sessions and personalized healthcare services at DHCs number roughly 5,700 people in attendance. CM can also play a role in cessation of smoking, acupuncture, and also special stickers on the ear can help people quit smoking, and this is an area being taken forward. Dr. Teck Chi-yun. Mental health has been receiving increasing attention in the recent years. So the policy address proposes a pilot scheme at 3 DHCs. Just then, the Secretary touched on this. But then he simply replicated the words from the PA without telling us the progress. So my question for the Secretary is that for the 3 pilot schemes targeting high-risk cases of people with mental health issues, how can we create a system for early detection? Will there be a case management model to ensure proper follow-up? What matters above all is to have collaboration between the medical, social, and community sectors. What progress do we see? I thank Dr. Teck for his attention to mental health. This is also top of mind for us. At 3 DHCs, we have a pilot scheme. In primary healthcare, DHCs are not expected to look after high-risk cases in mental health. DHCs provide screening. They provide assessment to help us spot people with possible mental health struggles at higher risk. We're not there to take care of high-risk patients with mental health issues. DHCs, upon spotting high-risk cases, refer those patients to appropriate organizations for follow-up. Now, on the collaboration involving the medical, social, and education sectors. The sector is for the entire community. There's no distinction as to whether someone is a student or not. At the schools, there's a 3-level system. Schools can also play a part. So every stakeholder works hand in hand with one another. They try to spot the high-risk cases. These people may be students or seniors. Thank you. Mr. Stanley. President, just then, I listened to the Secretary's reply about the role played by DHCs. A member asked about the role played by CM practitioners. The Secretary also gave a response. Here's my follow-up question. For the CM services at DHCs, would such services be standard services at DHCs such that every DHC would provide consistent CM services? DHCs coordinate services and act as case managers. The DHCs are not the primary service providers themselves. Doctors and CM practitioners don't provide those programs at the DHCs. On the contrary, DHCs work with the community bodies and stakeholders. This includes family doctors in the community and also CM practitioners. It's about creating this network where DHCs refer patients to appropriate services. Now, for the CM training and research centers, this is where DHCs refer patients to. In the past, the subsidy has gone up from $600,000 to $800,000 for services at CM outpatient care. Reverend Peter Kuhn. A study shows DHCs are mostly used by seniors or people who are older. Does the government have figures on this, and how can we encourage more young people to access DHCs? Secretary. On the figures, as at 31st of March this year, a preliminary figure is that at DHCs, roughly 3,400 members were below the age of 18. There are more senior DHC members. Many factors, external factors are at play. These people tend to be retired people. People of an advanced age tend to have more chronic conditions and they pay greater attention to their health. Young people may see DHCs as less relevant. Under the chronic disease co-care scheme, men appear to be less mindful of their health conditions. The ratio of women and men accessing the services are at 60 to 40. So more women access DHCs than men do. We get it. Health is something people should pay attention to throughout their lives. We will make a greater effort in the recruitment of members at DHCs. We will target different age groups, and we also want to encourage more men to pay greater attention to health. They shouldn't dismiss their health risks. We will promote such education. Our goal is to get everyone to actively take part in DHC activities. Now, on the attendance at DHCs, indeed, people of a more advanced age are more likely to access DHCs, and they are indeed also a priority group.
Question number 3, Mr. Perry Yu. President, there are views that the Victoria Harbour is an iconic tourist spot Hong Kong takes pride in, and the harbour tours are well received by visitors. However, there are views that vessels engaging in illegal operation of harbour tours have become increasingly rampant. Near Tsim Sha Tsui waterfront, with inadequate berthing arrangements rendering it difficult to protect passengers' safety. In this connection, we government informed this Council 1 of the numbers of Class 1 and Class 4 vessels that can provide harbour tour and the operational requirements of and restrictions on these two classes of vessels. 2, as there are views that some pleasure vessels have allegedly been engaging in illegal carriage of passengers in the vicinity of the Victoria Harbour and instantly charging passengers by means of soliciting of the numbers of inspections and decoy operations in respect of such vessels in the past year, and whether they have reviewed the effectiveness of the enforcement actions. And 3, whether it has monitored the usage of piers and landing steps during peak hours and holidays, and whether it has planned to enhance the facilities and formally crowd control measures to divert passengers, thereby meeting the increasing demand, if so, of the details, if not the reasons for that. Secretary for Transport and Logistics. President, the Victoria Harbour is one of the major tourist attractions in Hong Kong, attracting a lot of visitors to go sightseeing on shore and at sea every year. At present, marine tours and sightseeing ships are available in the market for tourists and the public to enjoy the scenery of the harbour. Navigational and safety matters in relation to the vessels are regulated by the Marine Department, or MD. Apart from providing licensing of local vessels and surveying services, MD also conducts routine patrols or special operations in Hong Kong waters to enforce marine legislation. If any vessels, including sightseeing ships, are found to have violated marine legislation, the MD will take follow-up actions under the law to ensure compliance with the license requirements and marine legislation. Regarding Mr. Yu's question, my reply in consultation with other departments is as follows. 1. According to the Merchant Shipping Local Vessels Certification Licensing Regulation, Cap 548D, Class 1 vessels such as ferries and launches are permitted to carry more than 12 passengers and mainly for the purpose of carrying passengers. Class 4 vessels can only be used by the owners or the charterers exclusively for pleasure purposes. Generally speaking, all local vessels, including the 2 above-mentioned types, are required to comply with the relevant requirements under the Merchant Shipping Local Vessels Ordinance, Cap 548, and its subsidiary legislation, such as holding a certificate of ownership, a valid operating license on board, and third-party insurance. In addition, the vessels must have on board a qualified coxswain and engine operators or pleasure vessel operators, and the prescribed quantities of life-saving equipment, firefighting appliances, and radio equipment, and must strictly adhere to the number of persons permitted on board allowed by their operating licenses. All classes of vessels must also meet the safety standards in the Code of Practice issued by the MD under Section 8 of Cap 548, specific to different classes of vessels, such as size, speed, nature of voyage, etc., to ensure that vessels with varying characteristics are properly regulated. Further, if a Class 4 vessel is let for hire or reward, the owner must obtain the Director of Marine's prior approval of and endorsement on the vessel's operating license. During the charter period, the written charter agreement or written hire purchase agreement for such vessels must be available on board for inspection by an authorized officer. As of May 2024, there were 265 Class 1 licensed vessels that can engage in sightseeing tours at sea, and 997 Class 4 licensed vessels approved by the Director of Marine to let for hire or reward. 2. From January 2023 to mid-June 2024, MD conducted a total of 230 site inspections and 17 decoy operations in various waters of Hong Kong, and initiated 23 prosecutions. Among them, 17 were convicted, and the legal proceedings for 4 are still underway. To safeguard navigational safety, apart from daily patrols and law enforcement in Hong Kong waters, MD also works closely with the Hong Kong Police Force, including conducting special joint operations during weekends and holidays to combat illegal carriage of passengers and violation of licensing conditions, etc. MD will continue to work closely with the police and review the effectiveness of the enforcement from time to time. In addition, to help the public identify Class 4 vessels endorsed by MD for hire or reward, MD has drawn up a list for public viewing. The list can be accessed by scanning the relevant QR code on pamphlets as well as posters and banners displayed in popular marine tourism spots. MD will keep updating the list. 3. Currently, on both sides of the central Victoria Harbour, there are a number of landing facilities, including ferry piers, public piers, and public landing steps for embarkation and disembarkation. Ferry piers are facilities used by franchised and licensed ferry operators. Public piers and public landing steps are public facilities open all day and for use by vessels so long as they comply with the marine regulations, not least in respect of safe embarkation and disembarkation. Regarding ferry piers, ferry operators are responsible for managing the daily operations of the piers. The TD also arranges on-site inspections from time to time to closely monitor passenger demand and maintains close liaison with the ferry operators with a view to upgrading the pier facilities to meet actual needs. Regarding public piers and public landing steps, the daily operation is handled by different departments as part of their scope of work. Generally speaking, TD is responsible for daily management, while CEDD for the maintenance and repair of the piers and landing steps. The government will review the usage of public landing facilities, engage the views of stakeholders to improve the design and usage of the landing facilities. The TD conducts a survey every 2 years on piers and landing steps under their management, including about 30 public piers and public landing steps in the central Victoria Harbour from Tsim Sha Tsui to Kai Tak and from Central to North Point. As observed, the daily usage of most of these facilities is not high, and the embarkation and disembarkation facilities with high usage is generally good and orderly. The TD will continue to review the usage and conditions of the piers and landing steps through regular surveys. Thank you. Mr. Perry Yeo. President, having listened to the Secretary, I'm still none the wiser. I still can't really make a distinction between Class 1 and Class 4 operations. Let me cite to a specific example to share my examples, and then I put my question. My experience is that in Tsim Sha Tsui, near the 5 flag posts, there are touts who approach me to go to the sightseeing vessel at the public pier, and they have all the scheduled the fare for adults and children, and there were 4 sailings per night. Now, these kind of touts and solicitation of passengers, is it legal or illegal? I asked the person, I was taken as a tourist, I was in casual wear, I was taken as a tourist, and I was solicited all the way to the clock tower and asked them whether they are legal, and they said they are operating illegally. Now, for the tourists, it would be hard for them to make any distinction, nor can I Is this kind of operation legal or illegal? Secretary. President, the member referred to that scenario. I think we have to look at it from two aspects. The first one is the CHOWs, and second, the legality of the vessel. I've said in my principal reply that for Class 4 vessels, there are two types. Class 1 vessels are of larger size. They're ferries, and people tend to be more familiar with the Class 1 vessels. For Class 4 vessels, as indicated in the principal reply, there are a couple of hundred of them in this category. And also in the reply, we said that to facilitate the members of the public and the tourists to identify whether the vessels on offer are operating legally or whether they get the approval to operate at the popular spots, we do distribute these kind of pamphlets regarding Class 4 vessels. And we also have posters near the pier or landing steps. We do have the posters whereby the members of the public or the tourists can just scan a QR code there in order to ascertain whether the vessels on offer have been approved to let for hire or for reward. As to touting, if they are charging for individual passengers, they are not really against the marine legislation. And this is a kind of mode of operation. Dr. Lam. President, thank you. My question for the Secretary is this. Will the Secretary replicate the same example as the taxi ambassador and designate the sightseeing ambassador at the pier to offer some guidance and support for the visitors who are patronizing these vessels? Secretary? Well, I think this is an eminently good suggestion. In answer to Mr. Perrier's question, I already said what we did and all the measures that have been taken, the pamphlets, the QR code, and the poster. I've mentioned all these. Now, the member raised this suggestion. The Transport Department is responsible for the landing steps. The Marine Department is responsible for inspection, and they will be looking at the arrangement for the vessels near the landing steps. And the Tourism Authority is also monitoring this. According to their observation, for inbound mainland tour groups, they tend to use these facilities in the evening more, like Tsim Sha Tsui. They engage in the embarkation and disembarkation in Tsim Sha Tsui for the harbor tours. And during the peak, it is still orderly, and there has not been any observation of chaos. As to whether we need to designate any ambassadors to do some publicity, the government is prepared to consider this. Mr. Robert Lee, President, in order to tackle this particular issue, will the government be using drones to monitor and record the black spots and take immediate law enforcement action? Will drones be deployed to monitor the public piers and the landing steps in order to formulate crowd control measures during holidays? Secretary, thanks very much for the recommendations. As I said in my reply to the earlier questions and also my principal reply, I said already that the various departments are monitoring the boat trips at the hotspots in the Victoria Harbour. At the present moment, from our observation, the situation is pretty smooth. But Mr. Lee asked whether there is any room to deploy high technology like the drones to assist us in our work. We're prepared to look at this if we find that the situation leaves something to be desired. We are prepared to do something about it, and we also see how the drones can improve the situation for the harbour tours. We're prepared to consider this. Mr. Kenneth Fogg, President, I've heard your reply to Mr. Perry Yu's question. I am a little bit bewildered, but the thing is, boat trips are pretty common. There are so many vessels involved, and there is a competition for berthing. And there are certain vessels that are monopolizing these piers in Kwun Tong, near the typhoon shelter. There are disputes over the berthing, and we've seen some criminal offences, and we've seen some fire, some vessels catching fire. I'm not sure they are related, but are there any measures to guard against these kind of events, and also to make sure there will be orderly berthing of the vessels and resolve these issues involving the berthing of pleasure craft? Secretary, on both sides of Victoria Harbour, Tsim Sha Tsui to Kwun Tong, the usage rate is pretty high also in Kwun Tong. Now, with regard to public piers and landing steps under the marine laws, if they berth at these facilities, they only use them for embarkation and disembarkation. And this is the requirement under law. If they are hogging the facilities, we will take enforcement action, of course. And we will step up the inspection to make sure that this kind of hogging of the facilities or abuse of the landing steps will be minimized. We'll definitely redouble our efforts and mount more inspections to make sure that these occurrences would be minimized. Mr. Frankie Yik, President, I'm not sure what I misheard the Secretary. He seems to be saying in answer to Mr. Perry Yu's question about the legality or illegality of the TOWs. Now, he seems to be saying that they are operating legally. Now, in your reply, you said that there must be a written charter agreement or hire purchase agreement. There has to be an agreement to allow the groups of passengers to get on board. They cannot be touting for passengers individually. I'm not sure, Mr. Yik, you put a question. Well, this is not a question. I'm pointing out the error. That doesn't have to be answered. He doesn't have to answer this part of my question, but I'm pointing out the error. Now, the second part is about the issues occurring in the Victoria Harbour. Now, you are telling us that you've done so many inspections. There were 23 prosecutions. Now, you haven't told us whether prosecution has taken place regarding Victoria Harbour. I'm telling you, this is not effective. That I can take you to Tsim Sha Tsui. There are dozens of these vessels that are operating illegally. We raised this question because these vessels are hogging the landing steps, and the bona fide operators cannot really use the facilities, and this is also giving rise to marine safety. Is how are you going to combat this problem? Secretary, President, Mr. Yik is basically talking about two things. Let me do this in the reverse order. In my principal reply, we said that in the Hong Kong waters, we have taken certain inspections for the Victoria Harbour in 2024, January to June, the Marine Department has, that's in Tsim Sha Tsui waters, 12 inspections have taken place. Now, that's in answer to the second part of the question. For the first part, as I said in my principal reply, for Class 4 vessels, they have to obtain the approval of the Marine Department before they can let the vessel for hire or for reward. Now, as to whether the tourists come individually or in groups, they are not really against the marine legislation. We have sought DOJ's advice on this one. Mr. Yik talked about the hotspots, and these vessels are hogging the landing steps. As I said in earlier replies, if they are monopolizing the landing steps without engaging in embarkation and disembarkation, they are on the wrong side of the law. And we are, in fact, stepping up the inspection together with the Marine Department and taking enforcement action.
Question 4, Mr. Holden Chow. President, it has been reported that in January this year, a child abuse case took place in the Tuen Mun district involving a 9-month-old baby girl who was taken care of by a home-based child carer, HCC, recruited by a non-profit-making organization under the Neighbourhood Support Child Care Project, the CARE project in short. In this connection, will the government inform this council? 1. As it has been reported that the baby girl involved was the first child entrusted to the care of the HCC involved in the case, whether the authorities will consider rendering more assistance to novice HCCs with less experience in the future by, for example, deploying another experienced HCC or professional child carers to accompany them to take care of the children for several times until they are experienced enough to take care of the children on their own. If so, of the details, if not, the reason for that. 2. Of the respective numbers of profit-making and non-profit-making organizations providing home-based childcare services under the CARE project in the Tuen Mun district in each of the past 5 years, and the details of the training provided by these organizations for recruited HCCs. In 3, given that in reply to a question raised by a member of this council on the 27th of March this year, the government indicated that since the launch of the CARE project, the Social Welfare Department, SWD, has received 4 reports of accidents leading to the injury of young children. Of the number of accidents proved to be caused by negligence of HCC after investigation and the improvement measures taken by SWD after each accident. Secretary for Labor and Welfare. President, the reply to the member's question is as follows. Regarding Parts 1 and 2 of the question, the SWD subsidizes non-government organizations to operate the Neighbourhood Child Care Project as CCP, which includes home-based child care service HCC as provided by the home-based child carers HCCs as their own residence or suitable place as approved by the service operators for children aged under 9, and the center-based care groups CCGs provided at the service centers set up by the service operators for children aged between 3 to 9. At present, there is one service team operated by an NGO set up in each of the 18 districts of Hong Kong, including Tuen Mun District, under NSCCP. SWD has all along required service operators to establish mechanisms to recruit, assess, screen, and train up HCCs and arrange service matching. At present, HCCs are required to receive 4 hours of basic training covering infant and child growth and development and care skills, child nutrition, and home safety, etc., as well as 1 hour of professional child care training provided by child care workers. Besides, social workers of the service operators are required to conduct monthly home visits to HCCs who are providing services, and the child care workers of the operators are also required to provide them with individual training or supervision on a monthly basis. Depending on the background and abilities of HCC, the service operators will also provide them with enhanced training or retraining courses, including training on the identification of child abuse and continuously assess and follow up on their performance. To enhance SCCP, SWD will strengthen the training for HCC starting from the fourth quarter this year, the content of which is standardized and formulated by SWD. Trainees are required to undergo 14 hours of basic training, including infant and child physical and psychological development, special development milestones and needs of growth, care and communication skills, home safety and hygiene, handling of accidents or special incidents, etc. And HCCs who are arranged to take care of children with special learning needs must receive an additional 4 hours of advanced training to acquire relevant knowledge and skills. Service operators are required to evaluate their childcare skills and knowledge of HCCs after completing the training. Their confidence in providing care services and whether the home environment is suitable for providing care services before arranging them to provide services. Under the enhanced HSCCP, apart from the existing home visits, training, supervision, and continuous evaluation and follow-up on the performance of HCCs, relevant figures on training or supervision will also be included in the service quality indicators, and the service operators are required to submit relevant statistical information to SWD on a quarterly basis. SWDB will also conduct regular and surprise visits to assess whether service operators are in compliance with the requirements of the service agreement. 3. Regarding the reports of 4 accidents leading to the injury of young children mentioned in the government's reply to a member's question on the 27th of March 2024, after investigation, the 4 incidents were merely accidents, that is, excluding suspected child abuse incidents, and did not involve negligence of HCCs. In response to each incident, SWD has instructed the relevant service operators to take corresponding improvement measures, including enhancing CCG's environmental safety, enhancing HCC's home safety awareness, as well as the precautions and care skills in taking care of children of different ages at the same time, and strengthening their safety knowledge and arranging outings for children. SWD will continue to remind various service operators of the need to continuously examine the assessment and service matching arrangement of HCCS and to strengthen the training for HCCs. Thank you, President. Mr. Holden Chow. President, the problems of HCC in Tuen Mun, we've been following up on them. The hourly rate of those HCC has been increasing. The problem is if we have enough supply of HCC, as mentioned in the main reply, we only have 1 service team that serve the Tuen Mun district. I wonder if we can engage more NGOs to operate such services so that NGOs can choose HCCs to provide such service to ensure the service quality and safety. Secretary. President, we have a tender exercise for NGOs to bid for provision of service under NSCCP. Such arrangement applies to all 18 districts. We have 1 NGOs that provides us service in each district, and we have a competitive exercise for the NGOs to compete for the provision of service. We have introduced a certain level of competition to make sure that the service quality is up to par. Dr. Dennis Lam. Thank you, President. The role of HCC is becoming more and more important. And the service quality depends on the capability of the HCC. I thank the Secretary for detailing the NSCCP. We have high requirements for HCCs. So my question for the Secretary is this, regarding training and how we can make the program more systematic so that we can have high quality and enough HCC to cater to the needs of the districts in the territory. Secretary. Thank you, Dr. Lam, for the question. Under the NSCCP, the training of the HCC is provided by individual NGOs. We propose that starting from the 4th quarter this year, the content of the training will be formulated by SWD. This is the first major change, and the number of hours of training will be increased as well. Previously, the HCC were asked to train for 4 hours. Well, starting for the 4th quarter this year, the HCCs are required to undergo 14 hours of basic training. So these are the 2 major changes in order to ensure the service quality of HCCs. Thank you. Next, Mr. Kenneth Leung. Thank you, President. HCCs are of great help to family, including dual income parents who want to work. We are concerned about children aged below 3 years old. After each and every incident, has the government done any publicity and education to instill confidence in parents in SCCP? Secretary, thank you. We have to make sure that HCC's service quality is up to par because they take care of children of special needs and infants aged under 3. We can improve their service quality through different means. First, we increase the number of hours of training. Second, we monitor the NGO so that they enhance their service matching to identify suitable HCCs. This project has been in place since 2008, and this is a very popular project. We want to enhance the basic training offered to HCC so that parents have more confidence in making use of their service. Thank you. Next, Mr. Tan Kap-yew. Thank you, President. I've been assisting the families whose baby girl was being abused, and gladly the baby girls returned to general wards from ICUs. People are concerned about this incident, so I wonder how will the SWD and LWB support the baby girl who's been injured and their family, and when will the legal investigation be completed? Secretary, thank you. The LWD attaches a lot of importance to the case. We're glad to see that the baby girl is recovering. We have a series of support and assistance to this family. We think that this family needs medical support currently, and as we can see, the Atuma Hospital is taking care of the baby girl. Now, in terms of welfare support, we are happy to provide such assistance to the family. As for this particular case, as is under the investigation of the police, it's not appropriate for me to make any comment at this stage. Ms. Doreen Kong. Thank you, President. Negligence results in dire consequences to children in terms of their psychological health. So I want to ask about the 14 hours of basic training offered by the SWD. I think that the length of training is not the most important thing. The most important thing is the content of the training. I went to the training course for the construction safety card. I think the government have to make sure that the trainees actually understand the content of their training. Secretary, thank you. I completely agree with what Ms. Doreen Kong said. We have certain standards for the 14 hours of basic training. This is a substantial increase in terms of hours from the current 4 hours that we have. The key is that we have to make sure that the trainees actually understand the relevant content of the training. As the SWD will be responsible for organizing the training, we think that the quality will be improved. I want to stress that actually most HCCs are dedicated to their jobs. I went to a ceremony that deliver awards to HCCs. We see that a lot of children are actually have a good relationship with their HCC. So apart from basic training, I think that we have to enhance exchange among different HCCs. We'll engage NGOs to see if we can organize exchange sessions for HCC so that they can learn from each other. Next, Mr. Chu Kwok-kan. Thank you, President. After declare interest, I am a director of a profit-making kindergarten. There is different level experience among different HCCs. That is why they offer service quality of different level. Now, it's very difficult for kindergarten to apply for certain schemes for after-school care. For example, the kindergartens have to meet high requirements for fire safety and equipment. And most kindergartens do not fulfill these requirements and they abandon the after-school care program. So will the government relax the barriers for kindergartens to apply for after-school care so that more kindergartens can provide care services to meet the needs of dual-income parents? Thank you. Secretary. Thank you. I don't think that his question is completely related to the NSCCP in discussion today. If kindergartens want to provide childcare service, we may be able to relax certain restrictions. However, some of the requirements are legal ones. For the requirements that are not legally related, if the schools meet certain requirements, that we will try to accommodate them, but each case is unique. We know that there is huge demand for childcare service. Perhaps after the meeting, I can talk to different interested kindergartens to see if we can allow them to provide such services. Thank you. Next, Ms. Lam So-wai. Thank you, President. Regarding this NSCCP, I know that there has been a number of incidents, so I wonder if the government should review the entire project to see if there is any systematic issue or problems with declaration. And I think that the administration should publish the result of investigation and announce any improvement measures that they have. Secretary. Thank you, President. NSCCP has been in place since 2008. Over 150,000 children benefited from the project. What is the goal of this project? It is to make good use of neighborhood resources. We want to have the neighbors to take care of children in the same district. Now, looking at the statistics and the response from the community, we know that the project is very popular. Otherwise, the government will not be dedicating more and more resources to the project. Regarding the 4 incidents, that was 4 incidents out of 150,000 children that have been taken care of under the project. In one case, a child fell off from a chair and the HC pulled him up and there was some lesion with the child's hand, and that was one incident. And there was another child who bumped into a playground and lost his tooth, and that's another incident. I think that you can call these home accidents. And after investigation, we found out that the injury has nothing to do with the HCCs. 115,000 children benefited. Only a few accidents have been seen. So I think that this is very rare, and we will try to improve the NSCCP so that families in need can benefit. Thank you. Next, Mr. Tony Che. Thank you, President. Apart from basic training or training the HCC, I think that the HCCs themselves have to be passionate about the service. I know that the Secretary has been in touch with the HCC to recognize them. I think that if we have HCCs exchange with one another about their childcare skills and experience. I wonder what the Secretary has done in order to facilitate such exchange amongst HCCs in terms of their childcare skills. Secretary. Thank you, President. The NGOs and the service operators are actually organizing such exchange sessions. Most service operators of NSCCP are knowledgeable in their own districts. So most HCCs are ones or people who live in the same district. As I've mentioned, every 2 years we have an award ceremony for HCCs, and in the ceremony we have HCCs share their experience, and we recognize HCCs that have served the community for a long time. Apart from providing service, actually the community and myself recognize the efforts and good work of HCCs. Through these award ceremony, HCC can share with the community their experience. Thank you, Mr. Shang Hailong. Thank you, President. The Secretary said that they provide NSCCP services at suitable locations. So I wonder what these suitable locations are. Secretary, thank you. Sometimes HCCs provide service at their own homes, and NGOs sometimes offer a space at their centers for the HCCs to provide care. We have to approve the center for the HCCs to provide service to make sure that is suitable. Next, Reverend Peter Kuhn. Thank you, President. Just now, the Secretary said that there was award ceremonies. For excellent HCCs, can we have the Chief Executive award or give them some awards so that more people will be willing to become HCCs? Secretary. Thank you, President. Thank you, Reverend Kuhn, for the suggestion. This year, we've elevated the ceremony to be hosted by the Secretary for Labor and Welfare, and we will see if we can strengthen and enhance the recognition to HCCs. Thank you.
Question 5, Mr. Paul TSE. Thank you, President. Many members of the public who are not civil servants, CS, have relayed that in recent years there has been a shortage of dental manpower and that the fees for dental consultations and surgeries have surged, which are unaffordable for both the grassroots and the middle class. There are views that the government should study the implementation of a scheme which is similar to the one proposing to procure dental services from the mainland for CS, to procure dental services from the mainland or provide subsidies for members of the public who are not CS in order to ease the plight of members of the public with dental problems through a two-pronged approach. In this connection, will the government inform this council, 1, as there are views that dental services affordable for the public are limited and that the main service targets of government dental clinics are CS, why the government procures dental services from the mainland only for CS but not for the general public at the same time? 2, of the estimated expenditure, service quotas, scope of treatment, and implementation timetable of the scheme under consideration to procure dental services from the mainland for CS, whether it has assessed the manpower in government dental clinics that can be released to serve members of the public who are not CS upon the implementation of the scheme, as well as the estimated number of beneficiaries. And 3, as some members of the public opine that the government's procurement of dental services from the mainland for the public will yield more immediate results and serve the public in a more practical way than spending hundreds of millions of dollars organizing the courtesy campaign Should Be Hearts Hong Kong and the Team Lab continuous exhibition, the actual economic benefits of which are doubtful and they are even expendable. Whether the government will, from the perspective of addressing the pressing needs of the public, at least procure dental services for the public from the mainland cities of the Guangdong, Hong Kong, Macau, Greater Bay Area, while studying the procurement of dental services from the mainland for CS, so as to give members of the public one more option. Thank you, President. Secretary for Health. I thank Mr. Paul TSE for showing a lot of concern over the dental services in Hong Kong. We attach importance to prevention, early identification, and timely intervention. We also encourage the public to develop good oral hygiene habits, and we raise public awareness of oral hygiene and health through publicity and education. In general, the need for dental treatment or surgery due to tooth decay and gum diseases can be greatly reduced if good oral hygiene habits are maintained. Agreeing to the recommendations made by the Working Group on Oral Health and Dental Care, the working group established earlier by the Health Bureau, the government should attach importance to prevention, early identification, and timely intervention in the future development of dental services with the goal of retention of natural teeth and enhancing the overall level of citizens' oral health. When considering the provision of government-funded comprehensive curative dental services, the long-term financial sustainability must be taken into account. It is more cost-effective to put the emphasis on preventive primary dental services. In consultation with the Civil Service Bureau, we provide a consolidated reply to the question asked by Mr. Paul TSE. At present, the government mainly undertakes publicity, education, and promotion of oral health, in particular with emphasis on nurturing good oral hygiene habits from an early age, including the provision of the school dental care service for children. Dental services provided or subsidized by the government mainly cater for persons with special needs in dental care, especially persons with financial difficulties or those with difficulty in accessing general dental services, such as recipients of CSSA, Comprehensive Social Security Assistance, and Old Age Living Allowance. Elderly persons in residential care homes, persons with intellectual disabilities, and so on. Besides, dental services are also covered by the government's Elderly Healthcare Voucher Scheme. The government's expenditure on public or subsidized dental services has been on the rise in the past years. The total expenditure increased from $886.4 million in 2020 to 21 to about $1.2753 billion in 2023 to 24, an increase of about 44% over 3 years. The government, in the future, will promote primary dental services to help citizens manage their own oral health for the prevention of oral diseases and the the government will develop appropriate dental services targeting underprivileged groups. On the other hand, it is stipulated that in the terms of employment for CS, that the government will provide dental care services for CS and their eligible dependents. The relevant services has been provided by government dental clinics under the Department of Health, and this is the benefits of civil servants. The expenditure is met by the dental clinics under the Department of Health. The expenditure is met by the resources earmarked for civil service medical and dental benefits. Such services do not form part of the public dental services provided to the general public. To ease the excessively long wait of civil service eligible persons CSEPs for dental services amid the increasing demand for civil service dental services, the CSB launched the pilot scheme on dental services dental scaling for civil service eligible persons CSEP. It was rolled out last year using the existing resources for civil service, medical, and dental benefits. Under the pilot scheme, CSEPs can receive dental scaling services in participating private dental clinics. The CSB is also looking into the feasibility of other proposals, including the provision of dental services to CSEPs in the GBA. As the CSB is still considering the related proposals and has not yet come up with any specific plans, no further information is available at present. Like the pilot scheme, any civil service dental services that may be implemented in the future will be funded by the resources earmarked for civil service medical and dental benefits. It will not be the resources from the public fund. As for the procurement of healthcare services from the mainland, the Hong Kong SAR government will not easily shift its responsibility of taking care of citizens' health to the mainland healthcare system, as it has all along shouldered the important role of protecting the health of Hong Kong citizens and providing them with quality healthcare services. When formulating cross-boundary healthcare measures, apart from supporting the healthcare needs of Hong Kong citizens who choose to reside in Mainland or use the services there, the Hong Kong SAR government will take into account the potential impact of such measures on the social resources and people's livelihood in the Mainland. For example, to provide emergency dental care services or continuous dental services, we need to pay special attention. Is it suitable to procure dental services from the Mainland? Taking dental services, well, based on the report and the 2023 policy address, the Chief Executive announced a series of measures, including the launch of the Primary Dental Co-care Pilot Scheme for adolescents and elderly persons not only benefit from dentures, but they can also benefit in relation to orthodontic treatment, dental scaling, tooth extraction, and so on. We will also extend the Health Teas Collaboration Scheme. We will also increase the quota. In relation to the Primary Dental Co-care Pilot Scheme for adolescents for those aged between 13 and 17, we will also collaborate with NGOs to increase emergency dental services targeting underprivileged groups with financial difficulties by providing an additional capacity that will be at least twice the current capacity of general public sessions offered by government dental clinics. The working group will issue the final report before the end of its tenure by late 2024. By then, the government will consider the various policy directions and recommendations on the development of dental services put forward by the working group. Thank you, President. Mr. Paul TSE. Thank you, President. As I understand, starting from 1947, the government has been providing CS with dental services. It has been 77 years, but the targets are only CS. Only limited emergency dental services are provided to the public. It has been so for the past 8 decades. We have started to see breakthroughs. For example, medical vouchers include dental services. Starting from the third quarter, there will be some clinics in Shenzhen that accept the use of healthcare vouchers. In Hong Kong, dental services are 3 times as expensive as those in mainland China. President, when the CS have this mechanism, why don't we consider improving the mechanism for the general public? It is to show care. It is not a kind of responsibility. It has been remaining so for the past 8 decades. Thank you, Mr. Paul TSE, for your question. The dental services provided to CS are benefits provided to employees, which is different from the dental services provided to the public. Let me give you an example. A bank may provide dental benefits to its staff. However, the bank only provides banking services to members of the public. So we cannot say when the bank provides dental benefits or dental services to its staff, then it needs to provide dental services to the public. That's very different. Mr. Kingsley Wong. Thank you, President. It is convenient and cheaper to receive dental care services in the mainland. In Hong Kong, it's much more expensive. The waiting time is long. The expansion of the elderly healthcare voucher GBA pilot scheme is very much well received. The organizations have been selected and shortlisted by the government. The quality is guaranteed. As the Secretary mentioned, dental care services are provided to people with financial difficulties or those on CSSA. Will the administration increase the number of organizations under the pilot scheme? And will the administration buy dental care service places to support those with financial difficulties, for example, those who are on CSSA or on old age living allowance, so the members of the public in Hong Kong can go to the mainland to receive dental services. Secretary. Healthcare vouchers are provided by the government to the elderly in Hong Kong. It is a benefit. It allows them to go to the private sector to choose the services that they need. We encourage people to take a preventive approach. For example, if they use $1,000 out of the voucher, then they can get an additional $500. So the Elderly Healthcare Voucher GBA pilot scheme is to exactly give citizens one more choice. It is not procured by the government. It is one more option for them. In 2023 policy address, it mentions that we will work with NGOs targeting underprivileged groups or those with financial difficulties. Will provide emergency dental care services. That's provided by NGOs. The number of GP sessions will be at least double the existing GP session quotas. Mr. Chan Kim-po, thank you, President. In the mainland, dental care was much less expensive, but the quality was not stable. It's only 1/3 of the expenses of dental care services in Hong Kong. Will the administration consider different proposals, for example, requiring the working group to look into the possibility of procuring dental care services from the mainland? Secretary, regarding the fees, many factors are at play. There are many different reasons behind the difference in the costs of dental care services in mainland and in Hong Kong. The government has the responsibility for providing services to the people in Hong Kong. We won't shift the responsibility to the organizations in the mainland. I need to emphasize we want to complement with the advantages of our mainland counterparts. We want to achieve a win-win situation. We need to focus on prevention. On treatment, we want to take care of those with special financial difficulties or the elderly in the RCHE or those with intellectual disabilities. Mr. Kisanyang, thank you, President. For the pilot scheme on dental services, dental scaling for CSEPs, $600 are sponsored. Some CSEPs told me only dental scaling is not sufficient. They don't mind going back to the mainland for dental care services. I visited a mainland city, dental scaling $100 and for filling $200. For extraction, $200 as well. Using the example of the secretary, well, the bank can give the money to the staff, and then the staff can reimburse the money after the dental treatment. So, secretary, can you work faster? Can you tell us the study results so that CSEPs will have a better idea of how they can use the public fund in a better manner? In the long run, we can also consider increasing the quota of the organizations in the mainland providing dental care services. As I emphasized, the provision of dental benefits is under the purview of the CSB. It is also stipulated in the contract of employment. The dental benefits are not part of the public resources. Instead, they are part of the dental care benefits of CSEPs. The CSB is still looking into the pilot scheme on dental scaling, how to make improvements, and whether we will procure dental care services for CSEPs in the GBA or in the mainland. Right now, the CSP does not have any concrete plan. They are still looking into the situation, and we will provide information when it's available. At present, we don't have further information. Mr. Stanley Lee. Thank you, President. Oral health may change one's eating habits. To a certain degree, it's affecting people's health. The Secretary attaches a lot of importance to people's health, but two issues will affect the health of citizens. In Hong Kong, waiting for dental care services is long. It's also expensive, whereas in the mainland it's cheaper, it's more convenient. Right now, the Community Care Fund provides subsidies, but there's a threshold. That's why it's unfair right now. Can we consider subsidizing the elderly to receive dental care services in the mainland instead of deducting the amount from their elderly healthcare vouchers? Otherwise, the situation will stay unfair in the long run. Secretary, the government has considered all these policies, including dental care policies. We emphasize fairness. The service of the elderly healthcare vouchers is to allow the elderly to make their own decisions. They can choose to receive the services in Hong Kong. Indeed, dental services in Hong Kong are much more expensive. But then they will have to bear the cost when they travel across the border. That is time cost and travel cost. So they can choose whether they will receive services in the mainland. So the elderly healthcare voucher program allows the elderly to make their own choice whether they will go across the border to receive dental services. Mr. Lam Chen Sing. Thank you, President. Dental services are rather expensive. It's cheaper in the mainland, but complicated procedures may cost up to thousands of dollars. The amount of elderly healthcare vouchers may not be able to meet the expenses. So will the administration consider increasing the amount of the vouchers and allowing the elderly to receive specified dental care services in the mainland? Thank you, Mr. Lam, for his question. In 2023 to 24, the expenses of elderly healthcare vouchers, when it comes to applications, was 413 million. That is the second most popular item. And our total expenditure reached $1.2 billion or so. As I mentioned, in a short period of time, the expenses have already gone up by 44%. We can see that the administration has been devoting resources in this connection. But as resources are limited, while considering elderly healthcare vouchers, different elderly persons have different needs. Some of them have dental needs, some of them have traditional Chinese medicine needs, or even Western medicine needs. Their needs vary. So we don't want to set any restrictions on specialties under the voucher scheme. We want to give the elderly freedom. We want to give them choices. We don't want to roll out, for example, dental care vouchers. Thank you.
Last question seeking an oral reply, Mr. Gary Chen. Thank you, President. It has been reported that the United Nations Environment Programme has warned that by 2050, up to 10 million people may die each year due to antimicrobial resistance. In addition, a study conducted by a local university has found that Xingmun River, Kaitai River, and the waters near various landfills contain residual medicines, including antibiotics. In this connection, will the government inform this council whether it conducted tests on the content of antimicrobial medicines, such as antibiotics, in local aquatic products in the past 3 years? If so, of the details. If not, the reasons for that. Of the measures in place to prevent the content of antimicrobial medicines in local waters, rivers, and aquatic products from exceeding the prescribed limits. Thank you. Secretary for Environment and Ecology. President, upon consultation with the Health Bureau, we provide a consolidated reply for the questions as follows. Antimicrobial resistance, AMR, refers to the ability of bacteria to evolve and become resistant to previously effective medications. When patients are infected with drug-resistant bacteria, their illness may be prolonged and may even increase the death risk. The misuse and overuse of antibiotics are the major factors leading to the development of drug-resistant bacteria. The government has been placing great importance on addressing the necessity of combating AMR. In 2016, the High-Level Steering Committee on Antimicrobial Resistance was established, chaired by the Secretary for Health and comprising members from various government bureaus and departments, including the Health Bureau, Environment and Ecology Bureau, Agriculture, Fisheries and Conservation Departments, AFCD, Department of Health, Food and Environmental Hygiene Departments, FEHD, and Environmental Protection Departments, EPD, as well as public and private hospitals, healthcare organizations, academia, and relevant professional bodies. The aim is to encourage professional sectors to collaborate and exchange ideas within the framework of One Health. In 2022, the government published the second Hong Kong Strategy and Action Plan on Antimicrobial Resistance, the Action Plan, outlining strategies to tackle the threat of AMR from 2023 to 2027. The objectives include optimizing the use of antimicrobials and promoting research related to AMR, such as the role and importance of the environment in the evolution of AMR. Citizens should pay attention to personal hygiene when using antimicrobials, including maintaining hand hygiene and following doctors' advice on antimicrobial use, and consult doctors or pharmacists as appropriate if in doubt. Under the One Health framework, relevant government bureaus and departments are working closely together through cross-sectoral coordination and collaboration to implement various aspects of the action plan. On the testing of antimicrobial drugs content relating to antibiotics on locally sold aquatic products, the Center for Food Safety of FHD collected around 4,300 locally sold aquatic product samples for testing antibiotics residues under the food surveillance program from 2021 to May 2024, among which the antibiotics residues content of X samples were found to be unsatisfactory. The satisfactory rate was 99.8%. For reference, the overall satisfactory rate of the routine food surveillance program from 2021 to 23 was 99.8% to 99.9% each year. So you can see that in terms of antibiotics residues, the content is comparable compared to is in line with the satisfactory rate. In addition, AFCD has launched the accredited fish farm scheme to enhance the competitiveness of local fisheries products. Under the scheme, aquaculture farms are not allowed to use any antimicrobials without prior instructions of AFCD or a registered veterinary surgeon. Aquaculture farms must also maintain records of the inventory and usage of drugs and feed additives. Over the past 3 years, AFCD has collected around 800 local aquaculture samples for testing, and all samples have met relevant requirements. For disposal of waste medicines, according to the Waste Disposal Ordinance, expired or ineffective waste medicines, including antibiotics generated by pharmaceutical suppliers or medical institutions, are classified as chemical waste. Their storage, collection, delivery, and disposal must comply with the requirements of the Waste Disposal Chemical Waste General Regulation Cap 354C. The relevant organizations are required to engage licensed chemical waste collectors to collect and deliver the chemical waste to the licensed chemical waste disposal facilities for incineration or proper disposal. EPD also issues letters to remind organizations such as hospitals and clinics to properly dispose of waste medicines generated, including antibiotics, in accordance with the legislative requirements. As for the small amount of waste medicines generated from domestic sources, they can be disposed of as general domestic waste. The landfills in operation in Hong Kong were designed and constructed as fully contained facilities with a multi-layer composite impermeable liner system covering the entire base area of the landfills. Waste undergoes anaerobic digestion in the landfill, and the leachate arising from the composition will be fully collected and treated at the leachate treatment facility set up at the landfill, including the use of sequential batch reactors for aerobic digestion. If the leachate contains residual antibiotics, the majority of which will have been removed before discharging into public sewers. On sewage treatment, over 93% of the population are now served by the public sewerage system. According to the research conducted by the Drainage Services Department, the sewage treatment works in Hong Kong can effectively remove most of the pharmaceutical residues, including antibiotics, in the sewage, for which the removal rate of some antibiotics in the secondary sewage treatment works can reach 90% or above. These findings are on par with those of relevant overseas research studies. The amount of the residual antibiotics in the treated effluents will have been greatly reduced after the sewage treatment process. To protect the quality of aquatic ecosystem for Hong Kong's marine waters and river waters, EPD has all along been implementing routine water quality monitoring program to provide data for water quality management and pollution control purposes. Regarding the impacts of residual antibiotic levels on the aquatic environment of Hong Kong, EPD commissioned a local university to conduct an aquatic environmental baseline study from 2020 to 2021. The findings showed that the residual antibiotic levels in local river waters, including Kai Tak River and Shing Mun River, were comparable to data observed in other highly populated cities in the world, such as London in the United Kingdom, Glasgow in Scotland, Brussels in Belgium, and Vienna in Austria. The levels of the residual antibiotics in the aquatic environment of Hong Kong were lower than the predicted no-effect concentration, indicating that there was no material impact on local aquatic environment. Thank you, President. Mr. Gary Chen. Thank you, President. Well, the government said that in the stream and river courses and water bodies in Hong Kong, the amount of antimicrobials is of a small amount, and also waste medicines generated from domestic sources in small amounts, so they could be disposed of as general domestic waste. But then there was a recycling program by an NGO, and they recycled 1.78 million pills, and each year there are tens of millions of dollars wasted on the disposed drugs. And it doesn't even count waste medicine disposed by households. And then, of course, they also contaminate the environment. Now, since you do teach the public not to abuse the use of antibiotics, why don't you also teach the public how they should dispose of medicines that they no longer need? Why don't you set up a recycling system under the public health, public hospital system? Under Secretary for Health. Thank you for the question. Now, the hospital authority has to observe safety standards. They will not reuse or recycle drugs, medicines that's been distributed, because after the medication has been distributed, there's no guarantee that they've been stored properly. For example, the medication has been stored in a very hot place, and so if we give the medicine again to someone else, we cannot ensure the safety and efficacy of the medicine. And also, we cannot be sure that distributed medicine has not been contaminated, affecting the efficacy of the medicine. So we need to make sure safety and quality as well as efficacy of medicines. So for this medicines already distributed, it will not be taken back for distribution to someone else. No, I'm not asking, you've got my question wrong, I'm not asking you to reuse the medicine, I'm talking about recycling medicine. Yeah, I haven't finished, actually. Now, the hospital found that it's more effective to deal with the issue at source rather than focusing on recycling. So that's why the HA has a series of measures to tackle the issue at source. We want to prevent patients from giving too much medicine. So we are doing education. We also have medication counseling centers. So pharmacists will teach the public how to use medicine. And then with our medicine dispensing system, we are not giving out too much medicine now. Maybe we'll just give medicine for months. And then for other medicine that don't need to be taken every day, such as paracetamol. So we may just give out medicine for a few weeks, and so they have to come back for more if they need it. And then we also have pharmacists or nurse clinics to teach patients how to use medicine properly. For example, blood thinners and medicine for asthma. So there's no need to stock up too much at home. And then we also want to develop the community pharmacy system. That means patients could keep just a small amount of drugs at home, and if they finish, then they could go to the community pharmacies to get a refill at a low price. That's very affordable. So we are taking various measures at source to make sure that there's no need for patients to keep too much medicine at home. Dr. Dennis Lam. Now, AMR could be a real serious problem. If there are superbugs, then doctors may use all the biotics at their disposal. Still, they cannot kill the bacteria or virus, and that could lead to a health crisis, actually. So, what is the situation like in Hong Kong in respect of superbugs or AMR? Now, how do we compare ourselves with other major cities in the world? Is the situation serious here in Hong Kong? Who will take the question, please? Thank you, President. Thank you, Dr. Lam. On AMR, we do monitor the situation closely. We find that compared to the other parts of the world, we are doing rather fine. Now, if we talk about AMR, we don't just look at antibiotics. We look at other drugs for fungus and virus and so on. We also monitor the wholesale level and supply of such drugs, because that's an indicator to show whether in Hong Kong as a whole we're using too much such drugs, and that may lead eventually to AMR. We also look at the indicators of the WHO. Maybe there is a certain type of drugs that can be used broadly that may have a smaller risk of leading to AMR, and the minimum is 60, there's a minimum standard set by the WHO that we watch carefully. So in terms of AMR, we believe that the situation is satisfactory here in Hong Kong. But of course, we would like to do more. The reason is, as Dr. Lam mentioned, if there are more super drugs that more drug-resistant virus or bacteria, there will be a smaller choice of drugs that can be used on them. That's why we need to keep AMR down. Mr. Chen Xiu-hong, thank you. Now, in the main reply, the Secretary said that waste medicines from households could be disposed of as general domestic waste, so there is therefore no plan to provide a service for collecting waste medicine from households or to impose any restriction. Now, the public may just flush away their unused drugs through in the toilet, and it will affect the level in our water bodies. And then in other places, they already have a scheme to recycle unused drugs. Mr. Gary Chan mentioned that last year an organization launched a community medicine recycling program with very good results. Now, the Undersecretary said that you are trying to reduce the provision of drugs at source, and so you encourage the public to just finish their course and not stock up on drugs. And then there's mention of, then the Secretary SEE said that by the time treated wastewater is discharged, there's already diluted level of drugs. But can we not put in place a drug recycling scheme? Because these actually are items that may pollute the environment, so we should handle or treat such waste properly. At the same time, we could take the opportunity to enhance public awareness on the need to on the benefits of recycling drugs. Why aren't you considering such a scheme? As Secretary for SEE. Let me first give a reply from the point of view of waste collection and disposal, and then US Undersecretary for Health will see if there's need to supplement. Now, when we consider waste recycling, we consider the two factors. Firstly, the impact of waste on the environment. If there are certain waste that will have serious impact on the environment, definitely there will be schemes to treat such waste. Chemical waste, medical waste are obvious examples. So another consideration is the amount of waste, because if a certain kind of waste is in a large amount, then it will be more. There will be more cost benefit in recycling the waste. So these are the two factors we consider. Mr. Chan mentioned medications or medicines. Well, yes, we have done much monitoring on the disposal of medicine, and then even if it's waste medicine from the household that gain their way to our landfill or to our sewage treatment plants, there will be proper treatment. So that's why in the environment, we don't see that in the aquatic environment that there is a high level of antibiotics in the water body. So we believe, therefore, the existing approach is sufficient to handle waste medicines from households. And if you consider the amount of waste medicines from households, it accounts for a tiny percentage of waste collected. So that's why probably there won't be priority for treating medicine. But in other places, they may have a different approach because they're concerned about the pollution caused to river or stream courses. But then in Hong Kong, we are highly urbanized. 93% of our sewage is 93% of population is covered by sewage systems. So there is collection of sewage in all parts of Hong Kong. But in other places, their cities may cover a much larger area. Their sewage treatment percentage, it won't be as high as in Hong Kong. And so that's why they may not have the same strategies as us in handling such waste medicines in river courses and so on. Now, perhaps the Undersecretary for Health would also like to supplement from the point of view of medical care. Undersecretary for Health, well, we believe it's more effective to tackle the issue at source. That is, we don't give out so much medicine. Now, we've done a lot on that. We need to explain to the patients why we're not giving them so much medicine. Actually, in particular for the elderly, because when elderly patients collect too much medicine, they don't even know how to use them. So that's why we provide a whole array of services. For example, at our district health center, there are pharmacists to explain to the public how they should take certain medicine. So we try to reduce the amount of medicine distributed. And then we'll also consider how we could refill medicine, because some patients may not want to go back to the hospital again for refill of medication. And so we are considering the community pharmacy approach. So each time people will be able to get a refill easily, and they don't need to stock up so much on medicine. Mr. Stephen Ho, I thank Mr. Gary Chen for his question. In his question, he said that the United Nations Environment Programme has warned that by 2020, up to 10 million people may die each year due to AMR. And then there's also the question of disposal of waste that may lead to problems. And then the Undersecretary for Health says that the issue should be tackled at source. So that's why it is really. That's why you actually chair the high-level steering committee on AMRs. If that's the case, you should try to tackle the issue at source by not indiscriminately distributing medicine. Now, the high-level steering committee on AMR always comes up with crazy release. They stop pig farms from using antibiotics. But if we feed antibiotics to pigs, and then eventually people consume the pork, the effect's not as direct as feeding people antibiotics. So tackling the issue at source, that is reducing the distribution of drugs. Now, from 2021, have you been keeping statistics? Are there any measures to deal with the possible risk of 10 million people dying each year from AMR? Undersecretary for Health. Well, I don't agree with you, really. Now, if you give patients antibiotics, then the impact is bigger than feeding antibiotics to pig. Now, because if someone takes antibiotics, you just take it for a few days, but then if you feed antibiotics to pig, so people eat pork every day. And then, so we have to consider how the supply of antibiotics from 2016 to 2018, there's a serious drop of supply of antibiotics by 40%. And then we see that in hospitals, clinics, or pharmacies, they are also using less antibiotics. So hopefully, then we'll be able to reduce the level of AMR. Thank you.
Government bills. This Council resumes the second reading debate on the extension of government leases bill.